The future for non-metastatic castrate-resistant prostate cancer looks extremely bright in the sense that we've gone now through all of our careers, and those of us who do prostate cancer every day, we've never had anything that we can specifically use for M0 CRPC. We've typically told the patients that we're just going to monitor you and we'll wait till you develop metastasis and then we'll give you a novel agent. We're at the cusp of having one or multiple novel oral anti-androgens FDA approved specifically for M0 CRPC. In the fall of 2017, both Janssen Pharmaceuticals and Pfizer Pharmaceuticals have had press releases stating that their respective drugs, enzalutamide and apalutamide, are effective in M0 CRPC, meaning that both drugs delayed the time to clinical metastasis in these patients without metastasis, meeting the primary endpoint of both phase 3 trials, both Spartan and Prosper. Those were the trials that we referred to earlier. That means that in a matter of weeks or months, urologists and medical oncologists could have new treatments available that we've never had before for patients with M0 CRPC.
The landscape of treating non-metastatic castration-resistant prostate cancer will change dramatically. In the past few decades, we've been tinkering with older drugs, some of which aren't even approved in this setting, such as ketoconazole. It's not even an FDA-approved agent in prostate cancer, hoping to get the PSA down and hoping to extend the time till metastases develop. With the advent of these second-generation AR-targeted agents, we will be using them sooner, for sure. And what does that mean later on? So if a patient, his cancer progresses on these agents, then he's more likely to get chemotherapy and other drugs when the cancer becomes metastatic.
Non-metastatic castration-resistant prostate cancer is an interesting entity because there's a couple of things that could happen. One is it could go away because with novel imaging agents, we might be able to detect metastases. And so it could be that some of the patients who 5 years ago and even today we think of as having non-metastatic disease have metastatic disease, but we're just not detecting it because we're not using the most sophisticated imaging modality. So over the course of the next few years, we're going to see data on PSMA PET and other types of new generation imaging modalities that might tell us that some of the patients who have non-metastatic disease actually have metastatic disease. So that's number one. Number two is I think that the future for those patients who have slowly progressive metastatic disease, slowly progressive non-metastatic disease, will be to preserve them into that non-metastatic state with next generation androgen receptor antagonists most likely. It's also possible that we'll look at immunotherapies in this setting, but I really think that the future in the short run is with integrating newer AR-targeted agents into this group of patients. The landscape for non-metastatic castration-resistant prostate cancer is changing because we will likely have therapies in that space, whereas previously we really haven't had anything. So this has been an area which actually I think is about 25% of our castration-resistant patient population, at least it is in some estimates. This is an area where physicians like myself have been treating patients with off-label therapies. We haven't had an on-label therapy in this group of patients, or we've simply been observing them, waiting for them to develop metastatic disease, which has always felt a little unsatisfactory, that we should have to wait for a complication or progression to occur before we intervene when we know that therapies may be beneficial. So I'm quite excited about the possibility of having a therapy that's available for non-metastatic disease because I can confidently tell patients that I'm going to have a significant chance for preventing metastasis from occurring.